This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. In this episode, we are talking about Parkinson's disease. So today our conversation is with Dr. Rodolfo Savica, who is a professor of neurology and a Parkinson's disease specialist at Mayo Clinic in Rochester, Minnesota. In fact, his work spans across all types of dementias and movement disorders, driving research and better understanding neurodegenerative conditions. So welcome, Dr. Savica, to our podcast today.
Thanks for the invitation, Dr. Chen.
So our discussion today is on Parkinson's disease, not just understanding it, but how to manage it, and more importantly, how do we live well with it? So just to start from the basics, what is Parkinson's disease?
There's a lot of confusion about Parkinson's disease. Parkinson's disease is a degeneration for the most part. We will clarify what I mean with that. So it's a degeneration of a group of cells that cause a dysfunction in some of the neurochemicals of the brain. Mm-hmm. What I mean is that because we are all producing a chemical called dopamine, is the chemical that allows us to be here today talking to you, have dinner later, have fun with our friends, overall help us in the daily life, whatever we want to do.
Right.
And for whatever reason, people with Parkinson's disease, the cells that contain dopamine are less, are dying earlier, and this causes a problem with usually movements, but not only movements. The fact that it's a degeneration means that it's a progressive disorder that causes the cell to continuously dying. Classically, we say that if you lose at least 50 to 70% of cells in one particular area of the brain called basal ganglia, which is deep inside the brain and contains dopamine, this is when the symptoms start.
Mm-hmm. And what is the prevalence of Parkinson's disease?
The disease is very common. Is the second most common form of degeneration after Alzheimer's disease. 2% of the population after the age of 70 has Parkinson's disease.
That's quite a bit.
It's quite a bit indeed. But after the age of 75, 2 out of the 4 symptoms of Parkinson's disease can be seen in 40% of the general population without them having Parkinson's disease as a mean of aging of the cells. Mm-hmm. So as we get older, there's an increased risk because aging is a component of that. There's vascular damage, there's things happening to the brain. I personally think that if we all lived 150 years old, we all gonna have Parkinson.
Yeah.
Why? Because our cells will die.
Yeah. So do we know more about why some people get it and others don't? Like, why do some people have more risk factors for Parkinson's?
Unfortunately, the problem is that there's not one single factor that we can pinpoint. Very simplistically, we can say genetics versus environment. We know that there are some genes, some mutations that people have that increase dramatically the risk of having Parkinson's disease. Yeah. Together with environmental risk factors, the combination increases the risk. But also some people that do not have any mutation and yet have Parkinson's disease. Why? Likely because they have a much more environmental weight into their life. When I talk about environment, I'm talking about lifelong exposure. Even before we were born, when we are in the womb with our mother, we are already exposed to risk factors. The food we ate, the oxygen we breathe, this is environment.
Right.
There are studies showing how pollution increases the risk of Parkinson's disease, how water wells contaminated with pesticides can increase the risk. So there's a number of important information for public health.
Yeah.
But ultimately, there are some people that are predetermined to have an increased risk.
I just have to ask the role of stress in all this, because I feel like our nation is chronically stressed. And I mention this because I have a handful of patients who are fine. And my observation is that they went through something very stressful, either a health issue or major surgery or something that changed their physiology. And then all of a sudden, like a year later, they start to develop symptoms. And it's like, is there some sort of correlation there?
Dr. Chen, that's a fantastic observation. As a clinician, you can see that. I also had stress in the sense of temporary cellular damage that can come from infection, as you mentioned, stress, surgery, anxiety, major loss, depression.
Yeah.
As you know, the inflammatory condition is a fuel to the fire. So clearly, it's true. Everything that you just mentioned so far, and I would add, the typical example we hear in a clinic is COVID. People had COVID, and after COVID, things went south. Why? Because COVID increased the inflammation, the systemic inflammation, the total inflammation of the body. It's true to say that these patients maybe were going to have Parkinson anyway. The stressors, the infection, the surgery just accelerated.
I see.
Made more manifest something that was going to develop anyway.
Okay, just
maybe
earlier.
in a few years. And that's an important point because it's telling, as you say very well, how unhealthy lifestyle, even mental health issues are a trigger for other diseases.
Have you seen a general trend towards a younger age of onset? What was the previous average age and what are you seeing now?
The average age in population ranges in between 65 years of age to 72, 73. And we were told that early onset, young onset Parkinson was something that happened only in very young people with a lot of genetic risk factors, in large families. They all have a gene that was defected. It's not the case anymore. We are seeing a constant increase at any age. The overall age is still around 65, but the number of patients that are affected by Parkinson, really, we are estimating a triplication of the risk, of the numbers.
Wow.
Triplication, so 3 times more, which is a lot.
Yeah.
Not just as we get older,
Yeah.
but also in the younger people. It's something that impacts the public health massively, the healthcare massively, not only with the aging of the population, but if we see younger individuals having Parkinson's disease more often now, those are people that, generally speaking, are still in the workforce, they still have young families, they're still active, and they're impacted by this condition. So it's a little bit different as a societal aspect, but also, most importantly, cause challenges when you're younger compared to when you're older. You, as an internal medicine doctor, a geriatrician, if somebody comes to you in 30s and 40s, you're not suspecting right away Parkinson's disease. Epidemiologically, you're thinking, can be something different. But sometimes there is. So why we are seeing this change, we are not yet totally sure.
Now, I want to spend some time kind of distinguishing between Parkinson's disease and Parkinsonism, which is,
Excellent.
A little bit different. But can you describe what the difference is and when do you see Parkinsonism as opposed to the disease process?
Absolutely. This is one of the sources of major confusion sometimes that you see between patients and also clinicians.
Yeah.
So Parkinsonism is a term that includes everything, including Parkinson's disease. So it's a bigger term. And Parkinsonism is a group of disorders where people are having some specific features and symptoms.
Yeah.
Basically stiffness, what we call rigidity, slowness of movement, what we call bradykinesia, tremor, and tendency to fall. If you have 2 out of these 4, this is Parkinsonism. And one of them has to be always slowness of movement, bradykinesia. Once we define Parkinsonism, then we have to understand the subtype. 80% of Parkinsonism is Parkinson's disease. So Parkinson's disease is the most common form. Usually the first appointment that people are getting with a physician, we tend to use the word Parkinsonism because we don't know quite yet what is what. But soon we will know. Parkinson, again, is the most common one, has some features similar to Parkinsonism, which include slowness of movement, falls, stiffness, and tremor. But the tremor needs to be at rest. The tremor has to be usually in one side when the hand or when the leg is completely at rest. It's not moving, it's not active. Sometimes people confuse the action tremor, the one that is present when we are drinking a cup of coffee and people are shaking, as a feature of Parkinson. It's not a feature of Parkinson, it's something different.
Yeah.
Other than Parkinson's disease, there's a number of other disorders. They are really like close cousins of Parkinson's disease, such as multiple system atrophy, PSP, CBS. They are very similar, but they are not Parkinson's disease.
Yeah.
And they're still called Parkinsonism because they're part of this bigger umbrella term.
Right.
But then is one of the subtype.
Yeah, I see a lot of patients with Alzheimer's dementia. In their late stages, they become more bradykinetic and slow, like you mentioned. They don't say as much, but they may not have the tremor aspect, but that can also be under the umbrella of Parkinsonism.
Absolutely.
Right? So if someone has not yet been diagnosed with Parkinson's disease, are there early ways that we can spot some signs and symptoms, perhaps decades beforehand?
Yes. Historically, we have been told that there's a number of symptoms that are quite specific. But when you see them in retrospect, so you can see after the diagnosis, you can identify them as present for 20, 30, 40 years.
Mm-hmm.
One of them is the lack of sense of smell, what we call anosmia. But anosmia is very common in many circumstances, allergies, COVID, and other things.
Right.
So it's not that everyone has anosmia. Another one that is very common, can occur 2-3 decades before the start of the disease, is constipation. But as you can imagine, constipation...
That's like half the population.
Half of the population. Or another one that is way more specific, however, is what is called the dream enactment behavior disorder.
Huh.
So they're having a bad dreams and they start to trash, to punch, to kick, to talk, to the point that sometimes they can be aggressive to their bed partners because they're dreaming of being assaulted, so they punch back. This is a condition that we know is a precursor of all sorts of disorder. And we know patients with this particular condition have more risk of developing Parkinson or dementia within 20 years.
Mm-hmm.
But it's fair to know and fair to say that when you ask our patients, sometimes you've been told that they have been doing this ever since they were kiddos.
Yeah, right. Well, you're describing my husband too.
Correct.
So.
And another important thing I want to mention about these symptoms, that for a while they were considered premotor symptoms. The one occurred before the tremor, the GE stiffness. And still, we have to understand that this is very valid for people that have late onset Parkinson's disease, people in their 70s and 60s and so forth. When people are younger, this is not valid.
Yeah.
That's not exactly what we see. And it's to do with the biology underlying the two different conditions. But this is a race. If I identify something that I know can then become Parkinson, I would like to do anything I can to stop it and to identify this early group of people. Currently, I think that people that have dream enactment, so living out their dreams, are the one that we should pay more attention to in terms of being precursor of the disease.
Mm-hmm. You know, as the symptoms progress, what do you feel like has been the hardest part for people to live with Parkinson's as far as the motor components, the functional aspects, and are there different parts of the disease that make it very difficult to live with?
I think that the most challenging part of having this disorder is that there's a group of patients that have what we call fluctuations. So in other words, they respond well to the medication, but they're swaying between having too much meds or too little meds. Therefore, the response is quite short, like maybe 1 hour, and the rest of the day they feel very bad. Nowadays, thankfully, technology has improved so much. We have a number of advanced treatment for people that is fluctuation, number of medication that we can use. The problem that we have nowadays is that we are still thinking that Parkinson's disease is one disorder, and it's not. And even when you have fluctuations, you cannot treat people the same way. They should be tailored for the patient. And this is what we are trying to do in Parkinson, tailoring medication, treatment, adjustment. That is challenging for the physician. That is challenging for the patients also, because sometimes you go online and you're looking for support and you find that your disease is quite different than somebody else.
Right.
and then you hear horror stories about how things have been terribly and bad, they maybe don't represent the truth. They represent one truth, one story, but it's not the global story of what's going on.
Yeah.
So that is, to me, the most challenging part.
And everyone's presentations are different, and everyone responds differently to treatment.
Absolutely so.
Yeah. Let's quickly talk about just the diagnostic part. Walk us through how you approach a new patient with a diagnosis. What does that process look like?
So in general neurology, in movement disorders, we are still put a lot of effort, a lot of time into collecting a medical history. A very good medical history is still the main part of our journey. Family history can be important, but it's more important to have the personal medical history, the symptom history, how things developed, and so forth. So every patient comes to see me for tremor. I will ask tons of questions to understand the nature of the tremor. So you see your physician, they ask you their questions. We are like to do the neuro exam. They examine you thoroughly to look at all the possible motor features of Parkinson's disease. Once this is there, you may have already a good idea that we are dealing with Parkinson's disease. If the features are not quite classic, you may order some additional tests. As we know, many people nowadays do a brain MRI, mostly to exclude other causes. It's common nowadays to obtain something called DAT scan. This is a scan that looks at the level of dopamine in some part of the basal ganglia. It can confirm the absence of the activity of dopamine, therefore can give me strength to start safely the medication, and can give me some information regarding the diagnosis, but is not able to differentiate between Parkinson and other Parkinsonism. It just tells us that there's a deficiency of dopamine. That's it.
And are there any other tests?
Nowadays, there are tests on the spinal fluid looking at the presence of this particular protein called alpha-synuclein, which is the protein that tends to accumulate in the most common cause of Parkinson's disease. It's a spinal tap, so we have to take some fluid from the back of the patients, look under the microscope, and see if the protein is present or not present. And again, it's not telling us more than that. Present, not present. Another new trend that we are seeing is this presence of skin biopsy, which is basically the same story, looking at alpha-synuclein in the skin. But unfortunately, the test has been, I'm sorry to say that, abused. People are thinking that with this test, you can know whether you have Parkinson or not. You cannot use this test to say Parkinson yes, Parkinson no. The test is telling us if you have an accumulation of alpha-synuclein in the skin. It doesn't tell you the nature of the disease. You may have an accumulation of alpha-synuclein for many other reasons. But let's assume that I am pretty sure that somebody has Parkinson's disease. I will tell them, I think you have Parkinsonism, likely Parkinson's disease. That scan was done, it was positive. Maybe order genetic test because they're young, maybe not, depends on what I want to be doing there. But I would say one of the most important things is to do an adequate trial with the medication.
Sure.
The medication I'm talking about is levodopa. So it's been around for a while. We know everything about this drug. It's still the gold standard for the treatment of Parkinson's disease. And if the patients are taking the medication properly, 1 hour before every meal, not with food, 3 times per day with an escalating dose, so increasing the dose every week up to the maximum tolerated dose. If I'm able to do that, I want to see 50 to 70% response.
Okay.
So it means that the patients will come back to us and tell us after a few weeks, I'm doing 70% better, 50% better. If this is the case, then you can say this is likely Parkinson's disease. And then, obviously, it's possible that with time, we have to adjust doses, changing a little bit the things, see what are the side effects. But this is the prototypical journey of somebody.
So I think the problem is that sometimes for patients, the difficult part is actually moving through those initial steps, right? Getting the referral and then getting to the proper specialist or to the geriatrician. And that's what can be the major initial delay.
It's not in the diagnosis, but in reaching the point when you are looking seriously at the diagnosis.
So how about the other end of the spectrum? Say, is there a role for all these tests to be applied earlier? You have a younger patient who can't smell. They're having some constipation issues, having dream enactment behavior in their early 40s. Is there a role for diagnosing them earlier? And does that change outcomes if they were, say, put on medications earlier before full symptom onset? Because to your point, we see patients when they're already coming in with advanced symptoms. And by that time, outcomes are different. They're already having Parkinson's disease and tremors. But if they're diagnosed younger and we catch them earlier, would that make a difference?
Let's preface saying that currently in all this field of neurology, we don't have a medication that can delay the progression of disease as a whole. If somebody's young, having the opportunity of approaching this test and catching something early can be relevant for a couple of reasons. In the meantime, you can improve the symptoms even earlier on, providing good years of living well without having pain, discomfort, tripping, falling on the ground, being slow, and so forth. But also, when somebody is young, we have to consider about alternative diagnosis. It's fair to call people early onset Parkinson disease before the age of 50, for example. But vast majority of these patients have something different. The features is Parkinson disease. But in reality, usually they have adult onset children disease. So in other words, they're pediatric diseases that occur later in life. And for some of them, we have a treatment already. This can change quite markedly the outcome of the patient.
And I know medications can't cure the disease, but in terms of prevention and reducing the risks, I went to one of your lectures where you cited quite a few studies to show exercise may have benefit to delay progression. So I guess my thought is, if we knew our risks of Parkinson's is high and we had that earlier diagnostic image of it, can we implement some of these lifestyle measures earlier on to prevent?
We have to. We have to. I mean, I would say everybody should try to have a healthy lifestyle in general, because this would reduce a huge cardiovascular risk factor, degeneration, but also can delay the progression of disease. We have experimental data on animals, on humans, showing that indeed the seniors that are active socially, mentally, and physically are the ones that are doing better. And the ones that are exercising, the ones that are doing this earlier on, the ones that didn't start later in life, the ones that have had throughout their life a good, healthy lifestyle, they can be affected by whatever condition, but they are better equipped to do that. And in Parkinson's disease specifically, exercise is key. We are talking about something that is affecting the movements. As such, we have to keep moving.
Right.
Unfortunately, in the evolutionary medicine, one of the reasons why people are thinking that Parkinson's is on the rise is sedentarism.
Sure. Yeah.
And sedentarism is not, I'm a couch potato watching reruns. No, it's not that. Up until 120, 130 years ago, if you had to go to work, you had to take a horse or to walk. You were always on the move. Nowadays, we are not as much. So even the most active people are still affected by this particular aspect of being sedentary, way more than our ancestors.
Can you share some personal stories of people that you've taken care of in your practice who've learned to live well with Parkinson's and managed to live with this disease process?
Absolutely. More than a single story, I would like to mention something more generic. That a lot of people have Parkinson's disease. We don't even know they have. So you can see them in the street. You can see them actors maybe. And if they're treated well, you will never know they have Parkinson's disease. People will be shocked that they have been having Parkinson's maybe for 10, 15, 20, 30 years.
Wow.
And we never know about that. You will never tell. And why is that? Because those are the people that are proactive, the ones that are careful, the ones that are doing the right things, the ones that are doing well. Let me tell you a story, though. I want to tell you about this patient that came from overseas with her husband. She couldn't walk. She was on a wheelchair. She came to my office on a wheelchair, so unable to walk a few steps without assistance. And she clearly had Parkinson's disease. So I started on a medication. And then I saw her back some times ago and she was doing great. One day she told me, I'm back. I want to see you. And she said, I don't know how I'm doing. I'm not sure. But they showed me the video of their wedding anniversary, 50 years anniversary celebration. And in the background, she was dancing.
Oh my gosh.
Dancing and I say, this is better than any test and examination.
Yeah.
In the background, when you don't know that somebody was watching, you were dancing freely and you were perfect. Nobody would tell you that you have Parkinson's disease. That's exactly, for me, much better than anything else.
That's a beautiful story. It's amazing what a little bit of dopamine can do.
Correct.
Not too much, though. You have to find that balance.
Whatever works for you, whatever works for the patient.
Yeah.
Again, as usual, it's individual.
Right.
But other than that, dopamine can do a lot.
What's in the future for Parkinson's management? There's stuff out there about stem cell transplants and these neuron repair treatments, gene therapies, hyperbaric oxygen. There are even clinics dedicated to just providing all these treatments in one place. You pay a lot of money for it. Is any of this stuff working? So,
short answer is no. All these activity you mentioned, hyperbaric chamber, neuro repair, even stem cells. Stem cells, this procedure that is very helpful for the heart, for the joints, for the liver. We cannot use this procedure for the brain.
Okay.
We don't have the technology to make sure that the cells are going back to the brain, number one. Number two, the cells of the brain are perennial. So you're born with a set number that can change a little, but it's a set number. So the same cells is with you basically all your life. Different in the liver, different in the joints. There's a constant turnover. That makes things way more complicated for the brain. So
that's all you got.
Correct. That's all you got. But there are no clear studies to suggest to use this procedure.
Okay.
And it's not free of risk. It's not free of risk. To me, if you ask me what is the future, is the individualization. Individualizing the treatment means that we will be able to identify the moment the patient we are seeing for the first time, we will be the group of medications, the group of treatment, the things that we can do to prevent the progression, or at least to stabilize the progression. That's what I mean with individualization. Customization of prognosis, customization of treatment, customization of the future, because one of the questions that I'm more stressed about, because I don't know to answer correctly, is that, okay, you gave me this great diagnosis, so what?
Yeah.
Now what's next?
Right.
And we're trying to answer this what's next, because that's exactly what will have impact in the life of patients. In addition, let me say another thing that is super important. One of the most difficult things that we have to do sometimes is taking the pills.
Sure.
Taking the pills on time, having the reminder 3, 4, 5 times per day, short duration, and whatever.
Yes, I absolutely agree. Prescription adherence is one of the hardest things for a lot of people. Are there any tools being developed that can help with that?
One of the systems that I think is very interesting is the subcutaneous delivery, which is already FDA approved and it's been approved in Europe already. The same concept of the diabetes pump, the pump for the insulin, a subcutaneous pump that people can remove when they need and would deliver straight in the bloodstream the medication 24/7. Medication would be levodopa, would help a lot of compliance, would help with the fluctuation of response. And the future is now means that we can use it now. And we are having quite success in the right candidate. I see that as the future. To me, that would be what almost everyone would do.
It makes sense. We need a steady stream of dopamine at all times.
Correct.
Yeah.
You don't need to go up and down, and you just press start once a day.
Yeah.
That's it.
So we have a closing traditional question for our experts on our podcast. What does aging forward mean to you? And how do you personally age well? How do you take care of your brain health?
The way I keep my brain healthy and try to age well is to be active and spend time with my family. But the most important thing is really working out and search for pleasure. That's crucial. And as we age, we are enjoying things that we couldn't enjoy before. So I see aging as an opportunity, not necessarily a loss. Because clearly I'm not in my 20s anymore.
Right.
At times I wish I was, at times I wish I was not. So it's an opportunity.
I really love that. And thank you so much for your time today and just giving us such a great overview of Parkinson's disease, how to live well with it. And, our goal of our podcast is not just to help us stay informed, but really help our listeners find hope and empowerment with how far science have taken us. So thank you so much for sharing that with us.
Absolutely. It's a pleasure being here.
On the next episode of Aging Forward, how to stay mentally sharp.
So that experience, you walk out into the parking lot and you can't recall, wait, where did I park today? And then it comes to you a few seconds later. That mild forgetfulness is common with aging. It may be easier for a 20-year-old to remember where they parked as they haven't parked as many times.
That's true.
They've only got 4 years of parking experience under their belt.
So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.